Hello, good morning, dear friends. Today we are going to discuss the myasthenia gravis. The terminology has came from the Latin words that it was myasthenia means muscle weakness and gravis as it was a grave or a serious disease. But with the advent of an immunosuppressive therapy nowadays, it is not such a grave disease if we treat it appropriately. We will discuss the disease. What is a myasthenia? Myasthenia is an acquired autoimmune disorder of postsynaptic muscle neuromuscular junction disorder characterized by muscle weakness and fatigability. The characteristic of the weakness is the patient initially won't have any weakness, but with the recurrent same exertions, patient will have a weakness. That's a repetitive functions, patient will have a weakness. What and how, that we will discuss in our pathophysiology. What is pathophysiology or the pathology? Normally, what will happen? We say the nerve. This is our nerves, and this is say the skeletal muscles. When the impulses is coming right from the nerves, there are the synaptic vesicles which will have say once the impulse is coming say around 150 to 200 of the synaptic vesicles which is containing of acetylcholine will be released once there is an impulse, and it will go down in this neuromuscular junctions attached to this acetylcholine receptors, and that will, if it is the large amount of a numbers, that will leads to stimulations of a muscle contractions. This is a normal physiology. Even in a normal physiology, what will happen? Once the impulse will pass down, the next impulse will have less vesicles to release. So normally we also get fatigue. Now in myasthenia, there is an acetylcholine receptors antibody. This antibody will have, number one, they directly attach to the acetylcholine receptors. Number two, with the formations of the complement mediated injury, they destruct the acetylcholine receptors and internalize the some of the acetylcholine receptors, ultimately lead to decrease in the acetylcholine receptors. This is a main pathology in case of a myasthenia gravis. What will happen now? Say as with the normal persons, the patients will have a normal release of the acetylcholine, but receptors available will be less than that of a normal persons. So in an initials there won't be an issues, but as there is a less vesicle release in a next impulse, the patients with the repetitive muscle stimulations will have an fatigue. Number two, many of the patients, so the acetylcholine receptors antibody are present in almost 85% of the patients with the generalized myasthenia and 50% of the patients with ocular myasthenia. Keep this in mind for your MCQ also. So these are the one receptors antibody. There are another antibody. Those patients who are acetylcholine receptors antibody negatives will have MuSK antibody, muscle specific tyrosine kinase. So patients who are negative with acetylcholine receptors, out of that 50% of negative means 8% of the people will have a MuSK antibody positivity. the second part, many of the patients will have thymic hyperplasia, around 50 to 60% of the patient, and 10% of the people will have a thymoma. So thymus is also involved in patients with this myasthenia gravis. Number 3, many of the patients will have associated autoimmune disorders like thyroid also. Now we will talk about the clinical manifestations. As we have said, it's most commonly affecting the muscles which will have the needs a very repetitive movement. So even right now you are sitting and hearing the lectures, which are the muscles right now we are utilizing. Even we don't. So the eye muscles that will constantly working even when we are at a rest. So the muscles involved most commonly will be muscles of eye, which leads to ptosis, diplopia, because the extraocular muscles will be involved and patients will have a double visions, and he is seeing with the two eyes. With the one eye he can see appropriately. So the most of the time ptosis and diplopia are the initial symptoms. This is called ocular symptoms, and those patients who is having an ocular myasthenia, out of them, if they will have no progressions, and if up to 3 years they are having only ocular symptoms, most of the patients do not progress to generalized myasthenia. It is said that in initial periods the myasthenia progresses more aggressively. Otherwise, once it is stabilized, it will remain stable. So the patient who is having only ocular myasthenia, if it is remains for 3 years and do not generalize, usually they do not have the progressions to generalized myasthenia. Patients which can have the involvement of bulbar muscles leads to difficulty in speech, difficulty in swallowing. So the patients will have a dysarthria and patient will have dysphagia. So and patient will have a involvement of facial muscles also, dysarthria, dysphagia. Patients will have also the involvement of facial muscles, which leads to sneer smiles, or the patient has a difficulty in smiling. Neck and back muscles can also be involved. Most importantly, when the respiratory muscles are involved, the patient is said to be in crisis. This is myasthenic crisis, because the patients will have rapid deteriorations and patient will require the ventilatory support. Now, the patient will have a neck, limb muscles, and almost all muscles will be involved. This is the initial presentation plan, then all the muscles can be involved. Who and which muscles will be affected, that is not specific, but it is said that those patients having anti-musk have more often bulbar muscle involvement than that of this. Now we talk about the diagnosis of the patients. How we will diagnose? The diagnosis of myasthenia once we have clinical suspicions on a basis of a patient is having the ocular muscle weakness, gradually and repetitive muscle stimulations leads to a weakness. So we have a bedside test like eye spec test, what will we do in the patient who complaining of an ptosis, we put the ice pack for a 2 minutes, then see whether the improvement occurs or not occurs. This is same because in a patient who is having in exposure to cold, there is a decreased impulse, so the patient will have better the contractions in a next contractions, but this is not specific. So we have this one test, we have an adrophonium test. Adrophonium is very short acting anticholinergic drugs, acetylcholine receptors inhibitors, which have around 30 to 45 seconds of onset. So very rapidly acting with 5 to 10 minutes of durations of actions. We give 2 mg of adrophonium to the patient. Let's see patient is improves or not. If not improve, we give another 5 mg of an adrophonium and then see whether it is patient is improved or not. Even this is not specific test because some of the patients who is having other disorders may have a mild improvement. We cannot have the objective assessment whether the patient is improved appropriately or not. Specific test or the serological test, these are very specific and should be done in all patients. As I said, and this is also important for an MCQ purpose, 85% of the patients will have acetylcholine receptor antibody of generalized myasthenia, and 50% of the patient with ocular myasthenia will also have acetylcholine receptor antibody. Out of those who are negative, means 15% of the patient, out of them 50% of the patients will have anti-muscle specific tyrosine kinase receptor antibody will be positive. There are one antibody, just to name it, that is LRP4. So we have understood 3 antibodies as far as the myasthenia is concerned. Now third type of an test, that is the patient we needs to have electrophysiological diagnosis. That is, we do the EMG, and in that we will do repetitive nerve stimulation test. When we stimulate the nerves, usually there is less than 10% decrement on a repetitive nerve stimulations. If it is more than 10% decrement, it is suggestive of myasthenia. And on a single fiber myography, electromyography, we have also an increased jitters if we use the 2 stimuli. So the diagnosis, bedside test, ice pack test, adrophonium test, serological test, acetylcholine receptors, anti-muscle, LRP for rapid nerve stimulation, and single muscle electromyography. So in short, we can say myasthenia, what we have understood, specifically acting on a muscle, mostly the ocular muscles. The patient who is an ocular weakness only and remains then limited to the ocular muscles for 3 years usually do not progress to generalized myasthenia. The patients will have bulbar symptoms, limb weakness, and the respiratory muscle weakness leads to crisis. The diagnosis is by the bedside test like ice pack test, adrophonium test, serological test, and electrodiagnosis test. Now apart from these diagnoses, what else we need to do? We need to have imaging for thymus, because thymoma is common in that patient. We need to have another autoimmune disorder. So we need to TS at level, and patient will have the chronic immunosuppressions. So we have to rule out the TB, the patient having an HbSAg or HIV, diabetes, because patient will be on an immunosuppression treatment. So we need to have rule out some this is which have an impact of this one. So this is all complete about the pathophysiology, clinical features and diagnosis. We'll talk on to the treatment part in the next